Welcome again. It's nice to be here. It's nice to have colleagues that work in my field. They create these pregnancies and I deliver them. I just want to give a bit of background in my own personal history. Like I said, I have two boys, age 4 and 7, and our journey was not without bumps. Like, we were never successful in the first try, but at the end of the day, it always works out because we have such good IVF success and we have such good doctors that just be patient, it'll work. Though we chose our egg donor, like my husband is mostly Ashkenazi Jewish, I'm mostly French, but we don't look alike, but we both have blue eyes and brown hair. So we found an egg donor that kind of looked like both of us. And that was the extent of our search. It was really not that difficult. And now our kids are 4 and 7, and it's really a joy, and I'm so glad to have been through that process myself. So in the process, in the medical process, like you've heard in the last few days, can be quite daunting and complex. And so we're going to discuss a little more in detail, a little more in a structured way, the medical aspects of gestational surrogacy. So it's in no particular chronological order, but I assigned a few topics to these 3 physicians to go over, and they have 12 to 14 minutes each, and if you don't stop, I will stop you, okay? And I made topics to them that are not the same, so there shouldn't be any redundancy, and if there is, I will stop you too, okay? So first we'll have Dr. Jerald Goldstein, who's a local here. He's going to discuss the issues pertaining to egg donors, the medical process of egg donations, the genetic screening of egg donors, and a few words about egg freezing and frozen egg banks. So thank you, Dr. Goldstein.
Welcome, welcome. So as George said, my mission is to talk a little bit about the process of egg donation, and hopefully these slides will make it more real for you. So in terms of picking out an egg donor, you know, I always tell patients that I see them, the first part is obviously of sitting down and talking to you and going through your history, and the second part is really picking out an egg donor. The process at our clinic really is we have a in-house egg donor pool, but also you can use we use agencies, and so agencies typically do the initial screening for egg donors, and that involves just advertising for donors, and then doing the donor screening, which actually involves doing testing. That testing from the medical part involves reviewing their records, as well as, for example, if they've been a donor before. If, for example, you are planning on doing like split insemination, where you and your partner are planning to use both your sperm to inseminate eggs, that you would look for different characteristics for a donor, as opposed to, for example, if you're a single guy and you're not planning on doing using both of your sperm. So when we look at egg donors, it starts with actually reviewing their records and reviewing if they've been an egg donor before. Involves looking at their prior stimulations, at their the number of eggs that actually were obtained when they did a retrieval, and then and last thing is I'll talk briefly about using an egg bank. So how are donors recruited? Well, they can be recruited in a variety of different ways. They're word of mouth. A lot of times donors will tell their friends. They're also frequently it can be found are recruited through Craigslist, applying to websites, either apply to egg donor agencies, as well as through universities, on the university newspapers. And after a donor applies to, typically to the clinic, if they're going through a clinic or if they're going through an agency, then they follow through with the process of the screening. Egg donors are typically, anywhere between 18 and 32. We personally, we have our clinic cutoff is 29. Although we'll also, if you find a donor, for example, if someone's used a donor and they've had a child through that, and the donor happens to be 31 or 32, well, then obviously there's then they would be, it's very reasonable to use them. High school degree. They're non-smokers, no history of prior STDs, that are, healthy, BMI less than 35, that they have access to their, prior family history, and that they have hormone levels that suggest they would be a good donor. Those hormone levels are primarily something called AMH, anti-Müllerian hormone, which is used as a screening tool to give us an idea of how many eggs that we could expect from the donor. Again, that they fill out before they even come into a clinic, that they fill out an extensive screening, which involves looking through a questionnaire, which basically goes through all of these different parameters to make sure that they have the characteristics that we would want in terms of for a donor. After they after they have the initial screening, then they come into the office and they sit down with a doctor who goes through, again, reviews their history, makes sure that the information they fill out on their questionnaire, height, weight, is what it is when you actually see them. Then they would go and have a physical examination, and that involves doing an ultrasound that looks at their, really we're interested in their ovaries as opposed to like a surrogate where you're looking at the uterus, and we look at the size of the ovary, the volume of the ovaries, and also something called the antral follicle count, which again gives us an idea of how many eggs that we could expect from a donor. It's also regulated by the FDA, the Food and Drug Administration, which requires us to get specific labs to make sure that that they don't have any type of infectious disease process that we could be that would be put a surrogate at risk. Lastly, is they have a psychological evaluation, and that is also really almost like a counseling session. So this to make sure the donor understands what the process is and what they're going to be going through, as well as looking for any type of issues that could be that would be worthwhile for you to know. In our program, we usually have that same person do the evaluation for the intended parents, where they can kind of talk to you and they can give you a little bit of an idea of who this person is, which is not specifically what the doctors are looking for. We're looking for their ability to be successful in terms of a donor, but they can give you an idea of kind of who that person is, personality-wise, and things like that. That can be really very helpful. Again, they have ovarian reserve testing, infectious disease testing, genetic counseling, and testing, and that involves doing testing to make sure that they're not a carrier for any sort of genetic disease in the psychological evaluation. The assessment, in terms of from a medical perspective, is the anti-Müllerian hormone, which again is something that you would probably want to at least ask your doctor just to have an idea of. Everybody, it's very standard in terms of testing. We typically want donors to have an AMH above 2. But if you have someone that, for example, has an AMH of 1.5, that in itself is not necessarily a reason to exclude them. Again, an ultrasound to look at their ovaries, and day 3 labs, which is called a day 3 FSH and estradiol. What about genetic testing? I know that we talk a lot about genetic testing, and basically when we talk about genetic testing, we're talking about you hear it in terms of with IVF and in terms of two reasons. The first reason is when we see a donor or we see a patient with screening, and that's actually looking to see if there's a mutation, if they have a mutation that would put them at an increased risk of having a genetic disease. And that's primarily like cystic fibrosis, for example, or sickle cell anemia, or Fragile X. These are screening that's done with the donor, so we, depending on the panel that the clinic uses, can screen for like over 100 different diseases, and that's done for all donors. That is different than the genetic testing that's done when you go through IVF and you're talking about doing testing for the embryo. Because when you're testing the embryo, you're not looking for, certainly when you're using an egg donor, you're not looking for a DNA mutation. Or you're looking for a change in the for chromosomes that numerically have like an extra chromosome. For example, the most common chromosome abnormality numerically is trisomy 21 or Down syndrome. And so when we talk about doing screening for the embryo, we're talking about looking for numerical abnormalities. So if they have an extra chromosome, or if they have a deletion, or there's part of the chromosome that's missing. And that's done after fertilization as opposed to the screening that's done in the clinic before, after you pick a donor. That's looking for a problem in terms of the DNA. So a little bit about the medications that are used for donors. So after we've seen a donor and they've gone through and they've been screened, they've had a genetic screen, they had a psychological screen, and they've signed the legal documents. The next part, which is the fun part, is really making a baby. And that involves using medications to stimulate the ovaries to produce eggs. So typically, women produce one egg a month. But when we're going through, you're using an egg donor, we want to have multiple eggs, so we place them on medications, which are injectable medications, to make it where they produce multiple medications. So it's a lot of medications that they're taking, and it's a lot of commitment for them in terms of it's of what they have to go through for the process. So it requires donors to be, obviously, we look for things to make sure they're punctual, they come to clinic, they come to the appointments on time, and things like that. Stimulation, typically, they're taking the injectable medications for about 10 to 12 days. The average, the average number of days is 10, but the range can be anywhere between 8 and 12 days. And during that time, a lot of times you'll hear from the clinic in terms of letting you know how the donor's doing and if she's stimulating well. Or, for example, there may be times when you're using a donor when in fact they aren't stimulating so well, and while they may anticipated. In our program, we typically, the average number of eggs is 17. The range can be between 10 and 25. But there are times that you start, despite everything that you do, you start people off and they may not be stimulating that well, and you may have to cancel them. So that a lot of times we want to do that before they actually have a retrieval, because the egg retrieval is really the more expensive part of the process. During this time of going through stimulation, they have ultrasounds, blood work every 2 to 3 days. So, for example, this is like, typically you have a donor and they're placed on birth control pills initially, believe it or not, for like two weeks or so, to stop their pill, have a period, and then they start taking injectable medication, and they have ultrasound monitoring for 10 to 12 days. After that time, they take a trigger shot that you'll hear that can be as Lupron, for example, or Avadril, which is basically, it causes a final maturation of the eggs, and then they and this is what an ovary looks like that's stimulated. You can see that each of those black circles is a follicle. So normally someone produces one follicle a month and typically ovulates between days 12 and 16 of their cycle. But when they're going through IVF, they have multiple follicles, and this is what this is basically what it looks like on ultrasound. After they take the trigger shot, then that's when they'll come into the clinic. Obviously, if the donor's being monitored locally, donor can be monitored locally, or we have donors that come in from out of state. They may have their monitoring done at another clinic, and then they come to our clinic at the very end, the last 2 or 3 days of stimulation, where they have a retrieval where we aspirate the eggs transvaginally, and then we fertilize them we fertilize them with your sperm. And so this is like what an egg looks like after they have the retrieval, and then they can be fertilized either naturally or with EXCI, where you can see where they're physically injecting a single sperm inside of the egg to allow fertilization to occur. This is what it looks like when we do a so-called FERT check, and then the clinic typically would call you up and tell you, oh, wow. This would tell you, so for example, you may start off with 18 eggs, let's say you may start off with 18 eggs and maybe we like to have 80% fertilized. You could have 16 fertilized, and then on day 3 you could have 10, and on day 5 you'd have at least 2, and anywhere between 2 to 8 or 9 embryos that are frozen. Before you freeze them, then they can be biopsied, and that's when we send them off to see if they're genetically normal, like we talked about, in terms of if they had an extra chromosome or deletion. And in our clinic, we freeze the embryos, and then we can, a week later, we let you know what we have, and then we do the second part in terms of seeing the surrogate and doing the transfer, which is really the fun part in terms of making the embryos. But there's a natural decrease. A little bit about frozen eggs. I know you hear a lot about frozen eggs. In our there are advantages and disadvantages to using frozen eggs. And most of the cycles we do involve using a fresh donor and taking all the eggs and doing like split insemination with you, as opposed to using, for example, an egg bank. If you are typically eggs are sold in lots of 6, and so out of a lot of 6 you can expect to have like 1 embryo. So if you were planning on doing, for example, split insemination, then it's usually not a good option for you. There is some advantages of using frozen eggs, and that is that they're immediately available, and that person's already gone through and done all the screening. But when you look at success rates in our program, it's about a 10 to 15% difference in terms of frozen eggs. Compared to embryos, and I think that's also true. Become pretty standard, and so the success rates aren't typically as high as using a fresh donor and having those eggs totally devoted, fertilized with your sperm and then freezing the embryos related to that. Any? Well, thank you. In terms of questions, we can talk later. Yeah.
Thank you.
I always get very nervous.
Thank you, Dr. Goldstein. Now I'm going to invite Dr. Hurliman to discuss the process of screening gestational carrier.
Tessa, she changes my slides. My person changes my slides. I sent it to her. I don't like all that crap in there.
Good morning. My name is Amanda Hurliman. I'm one of the physicians with Oregon Reproductive Medicine. We're a fertility clinic in beautiful Portland, Oregon. And I'm going to talk to you about a little bit more about the selection of surrogates and also how we evaluate intended parents. So who is the medically ideal gestational carrier? Our governing body in reproductive medicine is the American Society for Reproductive Medicine, and they have specific guidelines about this that have looked into who is the healthiest candidate. And so I'm just going to kind of talk through what the ASRM guidelines are. I think one thing to note is that guidelines are guidelines, they are not laws, and so you may find that in different agencies they vary a little bit from what I'm going to be talking through. But I think most importantly is that you want a surrogate to be both physically healthy and mentally healthy. It's very important that they have a very stable social environment and adequate support to help them through the process. They must be of legal age. The recommended ages through ASRM are 21 to 45. Some agencies have younger age cutoffs in the earlier 40s. And the reason for that is because as women get older, there are some increased risks for carrying a pregnancy. They must have had at least one uncomplicated pregnancy that resulted in the live birth of a child. But we don't want them to have had too many children. So the recommendation is to have had less than 5 live births. And the reason for this is because the more deliveries a woman has had, she's at increased risk for having some complications during pregnancy. And so we want to avoid those complications. Of those births, we would prefer that she have less than 3 cesarean sections. The cesarean section is when you have a surgical procedure to have the baby, and each time you have a C-section, you're making a scar on the uterus, and that scar doesn't have as much integrity as the rest of the muscle that makes up the uterus. And so it increases the risk for two potential things to happen. One, that scar can open prior to the delivery of the child. Or sometimes, depending on where the placenta implants, it can grow into the scar, and that is a very complicated issue to take care of. And so we want to minimize those risks, so having less than three C-sections is the way to do that. She should be a non-smoker and willing to refrain from alcohol and drug use during treatment and pregnancy, of course. I think different agencies have different BMI cutoffs. In our clinic, we use a BMI cutoff of 32. The reason for BMI cutoffs is that as BMI increases, it influences both fertility outcomes and also increases the risk of certain complications during pregnancy. And so we want to do what we can to maximize your chances of having success and also having a healthy pregnancy. So how are gestational carriers medically screened? The first thing that we're going to do is take a complete medical history. Oftentimes, we will request records from their previous, from their whole medical history, but specifically we want to know what pregnancy was like before and what delivery was like. Were there any complications? Are there any red flags there? She'll have a complete physical exam by a qualified medical professional and obtain clearance for pregnancy. And she and her partner will also undergo psychosocial screening by a qualified mental health professional. This is going to be a clinical interview. There may be additional psychologic testing if that's necessary. But one of the important things in this discussion is to consider the impact of what this journey is going to be like for the gestational carrier's family and community dynamics. Both the gestational carrier and her intimate partner will undergo laboratory screening. This is screening that is mandated by the FDA. You're going to see this panel of infectious diseases a million times, so I don't need to go through each one. The gestational carrier will also go through some specific testing, which can include a blood type, updated pap smear, a mammogram if she's over 40 and it's indicated, confirming that she has immunity to both varicella and rubella, and a urine drug screen. We also are going to want to evaluate the uterus to make sure that it looks like it's going to be a happy home for a baby. So there's two ways that we can evaluate the uterine cavity. One is the saline infusion sonohistogram. That's probably what we do most commonly. This is where just a small amount of fluid is placed into the uterine cavity. We do an ultrasound, take a look around, make sure everything looks good. She often will also have what's called a practice embryo transfer. This is so that we know the path to take through the cervix prior to actually doing the embryo transfer. So if there's some curves in the path, we know we can anticipate those before we're actually doing the embryo transfer. Some gestational carriers, but not all, will need to complete something called a mock cycle, which is where they will take the medications that are used to stimulate the lining of the uterus. They'll have ultrasound monitoring and blood work to look at their hormone levels to make sure that when it's go time, that everything's going to work well. So shifting gears, we're going to talk a little bit about screening of intended fathers. This screening is going to include laboratory testing, genetic screening oftentimes, and then an evaluation of sperm quality. And that's typically done with a semen analysis. The laboratory testing, again, is regulated by the FDA, and it is that same panel you're going to see a million times. The blood work has to be done within 7 days of providing the sperm sample that's going to be used for fertilizing the eggs. So the way that we do this is that typically when you provide the sample to be frozen, we do the blood work at the same time, and so you don't have to have multiple appointments or chase down lab results. A a physical exam is also going to be performed. Typically, that's just by your primary care provider. We've talked a little bit about genetic disease screening, and genetics are complicated. We're looking at a few different things here, and autosomal recessive carrier screening is the screening that is done before the embryos are created. This is looking at specific mutations that are known to cause specific diseases. Most all egg donors have had some level of autosomally recessive disease screening. There are many panels that are available, and so different donors may have had different panels. We use a specific panel at ORM that looks at about 175 different diseases. So if you had selected an egg donor that you found to be a carrier for a certain disease, then you would also want to have this screening done yourself. It's a blood test, and it's going to just look to confirm whether or not you're also a carrier. Because the simplest solution, if you found that you and the egg donor were both carriers of the same autosomally recessive disease, would be to pick a different donor. So a little bit about the semen analysis. A specimen is provided. We usually recommend 2 to 4 days of sexual abstinence beforehand so that we can make sure that we have an adequate sample. The lab looks at the total volume, how much sperm there is within each milliliter of that volume, how well the sperm are moving, and what they look like. That's the most important kind of take home from a semen analysis. It can either be ordered by your fertility physician or your primary care provider. So what do we do if there's an abnormality? Typically what we're going to do is we're going to repeat the semen analysis about 4 weeks later. It takes about 3 months from a sperm to be made until it's ejaculated. And so a semen analysis is really just like a Polaroid. It's like a screenshot of one moment in time. And sometimes something could have happened 3 months ago that you have forgotten about that could have affected the quality of the sperm at that time point. So we want to see if the abnormalities are persistent. And if they are, then depending on what those abnormalities are, we may do additional blood work looking at hormones and some genetic factors. And we likely would have you have a consultation with a male fertility specialist who's typically a urologist. And they would complete a thorough physical exam and discuss if there were any potential treatments that we could do to help improve the quality of the sperm. If there are issues with the sperm, those can typically easily be overcome through the use of intracytoplasmic sperm injection, and, or ICSI. So ICSI is performed following the egg retrieval, what happens here is that the embryologist is going to look at the sperm under the microscope, and they're going to pick up a healthy appearing sperm. You can see one in that little pipette right there. And then they're going to just place that little pipette in the egg and put the sperm there. And it works really well. There are certain recommendations for when and when not to do ICSI. Those include if there's an abnormal semen analysis, if you've previously done an IVF cycle and had failed fertilization, doing conventional insemination, which is where you just take the sperm and pour them on the eggs. Typically, if you're doing pre-implantation genetic screening, we want to avoid any risk of genetic contamination. And also in our lab, if we're using cryopreserved sperm, we're going to recommend using ICSI because fertilization rates are higher. So quite commonly, both intended fathers would like to provide a genetic contribution to their children. And this can be done very easily. So just kind of talking through what that process looks like. The egg donor is going to complete ovarian stimulation and have the egg retrieval. The eggs are then going to be evaluated for maturity. And then half of the mature eggs are going to be fertilized with each intended father's sperm. And the embryos are going to be grown in the lab, typically to the blastocyst stage. And then you will have made the decision about whether or not you're going to do pre-implantation genetic screening of those embryos. I have 2 minutes and one more slide. I'm golden.
What did you say? What did you say?
And then most commonly, we're going to be doing a frozen embryo transfer, and then the embryo or embryos are going to be transferred to the gestational carrier. So what can you expect to happen? Because what you have at the beginning is not what you're going to have at the end. And this often comes into play if you have two intended fathers, because you're splitting everything in half. So it is important that you have an egg donor who is going to provide a sufficient supply of eggs in order to be able to ensure that that happens well. So we do an ultrasound, and we see that this donor has 25 follicles. There's an egg in every one. So then she has an egg retrieval. And we don't always get an egg from every follicle. So say we get 20 eggs. And then of those, about 16 to 18 of them are going to be mature. Then we're going to fertilize those eggs through EXCI, and the fertilization rate's typically around 75%. So now we have 12 to 13 fertilized eggs. And then we're going to watch those embryos grow to the blastocyst stage, which is after about 5 or 6 days. And typically, these are based on data from our lab, 50% of those fertilized eggs are going to grow to the blastocyst stage. And those blastocysts can then undergo the pre-implantation genetic screening. And in our lab, typically with egg donor cycles, 30% of the embryos that are created are chromosomally abnormal, and 70% are chromosomally normal. So those are the embryos that you're going to have to be able to use moving forward. I'm out of time. Thank you.
Thank you, Dr. Hurliman.
No.
Now I'm going to invite Dr. Park to discuss the issues about embryo transfers, evaluation of the embryos, PGS, and what happens when it doesn't work out.
Hi, guys. I have a lot of material to cover, so I'm going to do my best to get it all done in time. Okay. Oh, I thought I did PGS first. The order of the slides changed? Oh, okay. Okay, so we'll start with embryo evaluation. No problem. All right, so this is an embryo fertilized egg already grown to 5 days. As Dr. Hurliman just explained, we grew it in the lab for 5 days. This here is your inner cell mass, which is the baby. And this out here is your trophectoderm, which becomes the future placenta. So if you're going to grade an embryo externally, just based on physical appearance, you look at the inner cell mass, how many cells there are, is it clear, is it symmetrical? You look at, same with the trophectoderm, and then you also look at this outer ring out here called the zona pellucida. You want to see how thick it is it pigmented? So for external evaluation of an embryo, just by looking at it, you can actually grade an embryo. But then there's the internal evaluation of the embryo. That's looking inside, and this is where PGS comes in, pre-implantation genetic screening. And what this looks at is inside each embryo, how many chromosomes there are, and the gender, 46XX or 46XY. So if you look over here, this is what all of us look like, from chromosomes 1, 2, 3, 4, 5, all the way to 22. And then this is the sex chromosome. Notice every chromosome, there are 2 copies. One came from the egg source, one came from the sperm source. But look over here, see how there are 3 copies of chromosome 21? That's a Down syndrome. Okay, so PGS is not looking at DNA mutations. PGS is looking at the chromosomes and just counting the number of copies of every chromosome. So some people call PGS CCS, comprehensive chromosome screening. Okay, so basically for PGS, you need to do what's called assisted hatching in the embryo, make a little opening. PGS now is done at the blastocyst stage, which is usually days 5 or 6, sometimes day 7. It's usually done on embryos that are good to fair quality based on external evaluation. You remove 4 to 6 cells from one location. And the removal is never of the inner cell mass. It's always out here of the trophectoderm, which is your future placenta. And it's removed with laser pulses at the cell-to-cell junction. So if you have not selected your carrier, and the goal is to freeze an embryo because you don't know who your carrier is going to be, embryos are frozen the same day as the biopsy, and you get the PGS results usually within a week. But if your carrier has been selected and you're trying to do a fresh embryo transfer into your carrier, embryos are not frozen. In our clinic, we'll do the PGS results. We'll get it back to you in 24 hours to allow for a fresh transfer. But the disadvantage of trying to do the second method is the biopsy must be performed on a day 5 embryo. But what if on day 5 your embryo isn't quite ready for that biopsy? I can't do that fresh transfer into your carrier. Okay, so there's a risk that I have to cancel the fresh transfer into your carrier because something unexpected happened. I'm going to come back to that in a second. So for PGS, if you're using frozen donor eggs, right, it's ideal to have the carrier selected so that I can allow for a quote-unquote fresh embryo transfer into the carrier. Because what I don't want, if these are frozen eggs, right, so now I'm going to defrost the eggs, fertilize with its sperm, create embryos, and if you don't have a carrier ready, I now have to refreeze that embryo, then I have to thaw it again, put it into your carrier. So if you're going to use frozen eggs, I prefer that you get your carrier ready to rock and roll, so I can defrost your eggs, get sperm, fertilize, and then I put it into your carrier. Okay? Refreezing the embryos, of course, is a possibility, but again, the freezing thawing is not ideal. If you're using frozen embryos, meaning that these were not fresh, you used embryos that you got from, because we have an embryo egg donor program. Again, I'd prefer that your carrier is ready to go to allow for a fresh embryo transfer. So the question is PGS worth it? Okay, and the bottom line is it's up to your individual interpretation. So consider this. If your egg donor is 20-something years old, as Dr. Hurliman mentioned, 20-30% of those embryos are not normal. So that means 70-80% are normal. Damage to the embryo from biopsy is really small. It's less than 1%. How accurate is it? Well, you biopsy only one location, and embryos are like soccer balls. They're not all one color. Some parts are one color, some parts are another color. And you're only biopsying one site. There's something called mosaicism, which is that parts of the embryos are different. Okay? And there's something called autocorrection, which is whatever's dominant on the embryo is thought to take over in a few days. So if your soccer ball is predominantly black with a few spots of white, ultimately that ball is going to become a black ball, right? So when you biopsy at this one location, I don't know if the biopsy site is really, because you only biopsy one place, I don't know if that biopsy site is a true representation of the majority of that embryo because I've only biopsied one site. Success rates of PGS, it really varies by clinic. Some clinics say it affects implantation rates. Some clinics say it affects their miscarriage rates and their live birth rates. Okay, so it's clinic dependent. In our clinic, we don't see a difference between PGS and non-PGS. The cost is somewhere between $4,000 to $5,000 minimum. But gender selection is important. If you have a gender preference, you have to do PGS. So is it worth it? You need to ask yourselves, are the results going to change the management of your pregnancy? All right, on to embryo transfer. So at this point, you've already created your embryos. Your egg donor sperm has all been combined. You grew it in the lab. Okay, so there are two ways to do an embryo transfer. First is fresh, meaning you select your egg donor and you carry at the same time. You create embryos. You do not freeze, and then you transfer right into the carrier. But the more commonly done, which I think is the more recommended, is frozen embryo transfer, which means you select your egg donor, you create and you freeze your embryos, and then you select your carrier, and then you transfer. Okay? So why do we prefer this? It's less stressful and less need for synchronization, right? It's just hard. It's so hard to find that perfect egg donor. And it's hard to find the perfect egg donor. Now you're still opening up profiles to find that great carrier. It's just overwhelming. Okay? The other thing is the quantity and quality of the embryos are known prior to the selection of the carrier. So you've selected your carrier and you donor at the same time. You're ready to rock and roll, and then you realize, oh my gosh, my embryos don't look that great. And you tell your carrier, hold up, I can't do this transfer. Meanwhile, you've already been paying her, right? Because she's been taking all these meds to prepare to receive this embryo. And also, egg donors, right, it's easier to find an egg donor than it is to find a carrier. But meanwhile, your egg donor is waiting months and months because you tell her, I've almost solidified my carrier, almost. You know, a month goes by, 2 months go by, and your egg donor is going to say to you, I'm not waiting anymore because she could have done a donation for somebody else. So it prevents the loss of an egg donor who's not willing to wait. Fresh versus frozen embryo transfers, if the embryos are good quality, there's really no difference in success rate. I will say, if this is, you know, you already have a child, you're coming back for baby number 2, and these are leftover embryos, and let's say you had to do 3 transfers to get baby number 1, now you come back for baby number 2, we usually transfer in order of best quality embryos to least quality embryos, so your subsequent embryo transfers may not be as successful because you used the top grade embryos for the first few transfers. But in general, the quality is good, there's really no difference. And over 95% of embryos survive freeze and thaw. Okay, so how do we do an embryo transfer? So embryos are thawed the morning of the transfer. There is no anesthesia. You use ultrasound guidance, and you could put the ultrasound on the abdomen or in the vagina. We usually do it vaginally, but it's the same. And you literally put a catheter in here and drop off an embryo, not sperm. This is not artificial insemination. You're putting an actual embryo into the uterus. No bed rest versus bed rest. The studies do not support that bed rest improves success rates. And in our clinic, we let the surrogates fly out the next day. Okay, this isn't a vacation for the carrier unless you plan to make it a vacation for her. She flies in, transfer, and she's out. So here's an embryo transfer. So this is the uterus. Oh, there's no sound. Okay, so this white line is my catheter. This is the endometrium where the babies grow. So again, this is a catheter. So keep your eye right there at the tip. Oh, see that flash right there? I don't know if you guys, right here. So that's the air bubble with the embryo. And so there it is. And that was all of, 10 seconds, okay? So the embryo transfer is done, and this is like the hardest part, is the waiting, the wishing, right? So what then happens? So, and all these tests can be performed wherever your surrogate lives. So your surrogate doesn't have to live in the same city as a clinic. Okay, so if your surrogate lives in Tennessee, and your clinic is in New York, she can monitor in Tennessee. So basically you do a blood test. The blood pregnancy test is called beta HCG, which is done 10 to 14 days after the transfer. The carrier has to continue her vitamins, her estrogen. Estrogen is what she uses to build the lining of the uterus. Progesterone is used to sustain that pregnancy. And then any other medicines, like if she's on thyroid medicine. Okay, 2 weeks after the blood test, you do the ultrasound, and that's where you could see, okay, the pregnancy. So, number one, you can see how many babies. So this is her uterus, and there's only one black circle, so she has one baby. Here's her uterus, but she has 2 black circles. She has 2 babies. Here's her uterus. She has 1 black circle, but 2 babies inside. This is one embryo that's split in her body. These are look-alike twins. These are not look-alike twins. So this came from transferring 2 embryos. And this came from transferring, it could potentially be 1 embryo, and it just split in 2. At 6 weeks, we look at the baby. It's really tiny. And then look at this 2 weeks later. So it went from less than 1 centimeter to about 2 centimeters. It's amazing, the change in literally weeks. Actually, there's no sound, so it's okay. All right, well, let's try. Baby A is 1.5 centimeters. That was the ultrasound of the baby's heartbeat at 8 weeks, but that's okay. So success rates. I'm just going to give you a various range because it does vary by clinic, but in general, you have a 60 to 90% pregnancy rate per embryo transfer, 50 to 80% take-home baby rate. Clinics vary by number of embryos to transfer. 1 embryo, some clinics report a possible decreased success rate, some clinics report no change. The advantage is that your risk of twins is less than 5%. If you put 2 embryos, some people believe it is a higher success rate. The disadvantage is your risk of twins is not insignificant, okay? All right, so then your carrier, let's say you do the pregnancy test and you realize she's pregnant, then you realize, oh no, there's no baby on the ultrasound. That's an example of a miscarriage. I'm just gonna explain the 3 types of miscarriages. Biochemical means her blood test is positive, but then she starts to bleed and then the blood test level just drops, which means she lost the baby very early in the process. Blighted ovum means the blood test is positive, you do an ultrasound, you see evidence of the pregnancy, but there's no baby inside. You just see the sac. A missed abortion means blood test is positive. You do an ultrasound, looks great. You see the baby, there's a heartbeat, and then for the next ultrasound, there's no heartbeat. The baby's still there, but doesn't have a heartbeat. So those are all the different types of miscarriages. But what if your carrier is not even pregnant at all? Then what do? You stop the medication, and she will have heavy bleeding. And then with the next period, if that blood test is totally negative, she can start up again. But at that point, I suggest you meet with your physician, go over the cycle, and figure out strategies. But this is important to remember. The most common reason after one unsuccessful embryo transfer truly is bad luck. Okay, most of these cycles result in a positive outcome, if not in the first and the second embryo transfer. Okay, but if she's not pregnant again, everybody's pissed off, right? I mean, obviously you guys are pissed off, but so are we. Like, we're disappointed, all the agencies, everybody, because we're all rallying to give you guys success. And so really, because I have 20 seconds, what you guys need to do is back to the drawing board, right? So figure out, is it an egg donor issue? Look at the egg donor's history. Is this a proven egg donor? Look at your carrier. Okay, do a full evaluation of her all over again. Is it the sperm source? If one of you had a great outcome and the other one didn't, okay, it says something, okay? But if she's not pregnant again, look at the clinic. Maybe this isn't the right lab, okay? And that's okay too, okay? But the bottom line really is that most of you will have success, if not the first and the second transfer. Thank you.
Thank you very much, everybody. Again, about my journey, we had our first child almost 8 years ago. We tried to have a baby again 2 years later. And interestingly enough, we used the same gestational carrier. And after 3 transfers, we were not successful. So, of course, everybody was pissed off. We were sad. We were, what are we doing wrong? What is she doing wrong? She's taking her meds properly. So after... sometimes you just don't know what to do. I don't think anybody knows why it works sometimes and not other times. So we switched surrogate because it had failed after 3 transfer. And then we waited a few more months. And the first try with the second surrogate, we had a good outcome. A pregnancy with a single embryo transfer and a healthy baby. So sometimes you don't know why, but you're just going to regroup. And this is it the egg donor, is it the surrogate? But eventually it works out. Questions for you. Dr. Hurliman, you talked about the evaluation of the gestational carrier. And I think you'll agree, all of you, that sometimes things are very subjective. And they say a good medical history. Sometimes I'm presented with potential gestational carrier that had 3 nice deliveries, but they had a history of smoking pot in college, or anxiety disorder, or they had diabetes for the first child, but then not for the 2 pregnancies. So sometimes it's difficult how to clear a gestational carrier, because I don't think any gestational carrier has a totally spotless history. So can you comment on that sometimes?
Sure. And I didn't really go through that in my slides, but there's a very long list of exclusion criteria where if we see those come across, they're not going to be selected to be a surrogate. I think different agencies, different clinics operate differently. We actually do the medical screening for some surrogacy agencies where all of their medical records come through us, and we review and determine whether or not they meet the medical criteria to be able to be a surrogate. So we have a team that reviews the records, and then but there's always that something, like, is this really a problem? And so when those issues arise, they're brought to a bigger group, that's a larger group of physicians, where we kind of talk about what the issues are. We may refer for a consultation with maternal fetal medicine to get their input to determine whether or not moving forward would be a safe decision.
Thank you very much. The ASRM came out with these guidelines 13 months ago about single embryo transfer. And how do you counsel the couple that's really pushing you? And I know you deal with this all the time, that to transfer two embryos and twins. I know I have my little spiel that I gave you yesterday, is that of the whole process, that's the only thing you can actually control and put yourself in a low-risk situation rather than a high-risk situation. But how do you convince your IPs to go one at a time? All of you.
For all of us.
IPs, you guys are not children. You guys are adults, right? And so I really believe in informed decision. And so I just give the facts and I tell them transferring two, and if you do, there's a risk of twins, and if you do have twins, there are pregnancy complications, right? Diabetes, high blood pressure, preterm delivery, the need for bed rest. You have to pay for her any workers' comp that she needs. You have to pay for somebody to come clean her house if that's what she needs. The risk of delivering early, and then your kids may end up in the ICU, and they may or may not have remnant disabilities from that. But I will tell them that in most major cities, most twins in general do fine. And I tell them, what will make you more upset? That if I transfer one and you're not pregnant, or I transfer two and you have twins? And that's ultimately the way I end the conversation. I say, you think about that and let me know. And whatever decision you make, I will fully support you as long as you've assessed all the pros and cons of each decision.
Great. I forgot about you guys. And I think it's the right forum to open it for questions if any medical question that you may have. Anybody? Yes.
The blonde lady
The blonde doctor.
Yes.
Breeze part about the RH disease.
Oh.
You check for all that?
Yeah, so the gestational carriers, whoever's carrying the pregnancy is going to be screened for RH factor. And it doesn't have any implications up front. But so if the gestational carrier is RH negative, meaning that there's not this factor on her blood cells, and the baby is RH positive, then the carrier's body recognizes the RH factor as foreign, and it creates an antibody against it. And so in future pregnancies, or if from previous pregnancies, there's a risk for something called isoimmunization. Most women, everybody is screened for RH factor and receives treatment during pregnancy with something called RhoGAM, which is going to prevent isoimmunization from happening.
I deal with this all the time. As a high-risk OB, that's what I do. 15% of Caucasians are RH negative, and we see a fraction of 1% of women who are RH negative have complications. So by and large, it's not an issue. I don't know why it's the second question I have about this today. It's a non-issue, or almost a non-issue. We won't have any more difficult time finding you a carrier or an egg donor. Please don't make, there's so many things that are important. This is not one of them.
I think it's important. A lot of times we talk about things that we look at that we have to screen for, but it's like if you go out typically and you meet someone, it's not like, you're like, well, what's your blood type, and I'm not going to talk to you anymore, or things like that. I mean, it's just that it's like it's really things can be magnified in this situation, but it's not practically. It's not certainly not a reason to select somebody.
It has no implications on your chances of success.
Yeah.
Any other questions about, yes?
So the exclusion criteria, are the women who are trying to be surrogates, there have to be online forums or availability to who's been rejected, discussions among them. Are those exclusion criteria public? How much of that becomes common knowledge? Does it evolve? And have there been more recently that have been included on that list?
Well, ASRM has specific what they would recommend for exclusion criteria, but I think every clinic it's going to have its own exclusion criteria. So you would want to speak either to the surrogacy agency or the fertility clinic to better understand what their exclusion criteria is.
I think the ASRM left it rather vague. You've got
Yeah.
a good point. Which is a good medical history. What does that mean? I participate in some of the surrogates forums for surrogates, and it's incredible having surrogates like, oh, do you think I can be a surrogate? I had cancer 3 years ago. And the other one's like, oh, yes, I've been a surrogate many times. I had cancer multiple times. Like, come on, who on earth would clear a gestational carrier with a history of cancer? Like, but some things are very benign, and they're rejected. Like, oh, yes, one of my boyfriend dumped me at the age of 19. I had 6 months of anxiety and took Zoloft, and now I'm 30 and married. It's not an issue. I've seen some surrogate being rejected for that, and I think it's kind of ridiculous.
Yeah. So I think we try to look at everything on a really individual basis and be like, is this a risk or is it not a risk? And some of the other things that on that slide that with the 5 live births, this may be your first child and it's the surrogate's live birth, and you may want another child and you may want to use the same surrogate. So it's unlikely, if there were not complications, that we would say you can't use that surrogate anymore because now she's had five deliveries. We would look at the risks and make exceptions.
I totally agree. I work in a very multicultural hospital in Queens, and we have women coming for the 6th, 7th, and 8th child, and sometimes, usually, everything goes very smoothly. So sometimes I have like a woman who is super healthy. The only issue is that she has 6 live births. What's the 7th, really? If she's willing to do it, she's otherwise healthy and thin. You know, what happens with age is that, I've seen it myself, you'll see it one day, you gain a few pounds. With gaining a few pounds, you're more likely to be hypertensive and have other complications, which bring my other question of the most common medical problem, that's the elephant in the room, no pun intended, is obesity. So sometimes you have a very healthy surrogate with BMI of 35. What's your take on this? Do you think it's too strict for using BMI of 32? Is this clinic dependent?
We use 35.
35?
35.
Okay. You use 32?
We use 32.
Yeah.
So we use 32. However, if that surrogate's your friend and her BMI is 35, we'll counsel you why she's not the ideal surrogate. But I get it, right? She'll save you a lot of money if you use her than if you go and pay a surrogate. But so as long as we're counseled and you guys understand, we'll move forward even for BMIs 32 or 36.
Sometimes, though, they'll be motivated to make lifestyle changes and lose weight.
Mm-hmm.
Right.
Sometimes.
That's not an easy task. Now, sometimes things go very smoothly, and that's great, and they'll want to use the same surrogate for a sibling journey. I usually recommend 18 months between deliveries. How about you?
That was supposed to be one of my slides. Sorry. We recommend 18 months. I don't know. The CDC recommends 2 years. But most, and the reason for that is because having a short interval between pregnancies has been associated with some complications with pregnancy, including having smaller babies and preterm labor and preterm delivery. But most studies show that those happen after 18 months. The CDC is just kind of covering some extra time there. And so I think most clinics are going to recommend 18 months.
And I think this is sometimes where you're going to see, you as the intended parent, you're getting information from the agency, from the clinic. Like last week, I got an email from one of the agencies after my staff had already told them, we're going to wait 18 months. No, we can't expedite this. And the agency, of course, sends me a private email saying, so can we just move her forward a little bit? It's just a few months. And I, respectfully said, I get it. I understand everybody wants to move forward, but I don't think it's in the best interest of the intended parents to move through the process forward. Protocols are in place for a reason. And you guys are sort of in the middle because you really want to move forward. And the agency is saying, no, it's fine, it's fine, it's fine. And we're saying no. But I think it's important you guys understand the goal of this is not just get these embryos transferred. The goal is to give you a healthy baby. And sometimes that means waiting a little bit longer, but it's worth it.
All right, I think you guys have been really a terrific audience, listening to words like uterus, ovaries, vaginal ultrasound, estrogen, progesterone, C-section, vaginal birth, placenta. Do you want more? No. So thank you very much for our panelists. It was really enlightening.